أولا مساء الخير. خالص الشكر للدكتور مجدي. وبعدين أنا موجود في أقوى سيشن النهاردة، 3 زميلات فنتوقع الكثير منهم. And I'm going to share the session with my colleague دكتور أيسر، دكتورة منى نعيم، ونبدأ بالأستاذة الدكتورة عزة الفقي Head of Cardiology Department at شمس. She's going to talk about the right ventricle and sports, the role of different imaging modalities. اتفضلي.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Dr. Magdi for this invitation. Thank you very much in this prestigious conference. Thank you for the presentation. Thank you very much for the chairpersons. I'm going to talk about the athletic right ventricle and the role of imaging modalities. It's a bit strange that we're going to think about the right ventricle and not the left. It's the one which is having the hazard more than the left. Strange enough. I have nothing to disclose. This is my agenda. And as a beginning, the athlete is defined as the individual of young or adult age, either amateur or professional, who is engaged in regular exercise training and participate in official sports competition. What do we mean by official sports competition? Is those who are organized and scheduled in the agenda of athletic associations. Long-lasting athletic training induces an overload on the heart, causing structural, function, electrical, adaptive changes known as an athlete heart. The amount of this heart remodeling is traditionally balanced between the two ventricles on the right side and the left side of the heart. During intense exercise, we mean by intense exercise, which is more than 10 to 15 hours per week, regularly for a long period of time, the right ventricle and the right heart is exposed to a disproportional afterload. Wall stress over a long period, which can be more pronounced, which causes more pronounced exercise-induced changes. Highly trained athletes, especially those involved in endurance sports, the type of sports differ a lot. The endurance sports, which means like cycling and so, can develop marked right ventricular remodeling that raise the suspicions of an underlying pathological disease. We have to differentiate then between the pathological changes and the physiological changes. What about the right ventricular and pulmonary circulation adaptation to exercise? During resting conditions, which is normally, the right ventricle and the pulmonary circulation is of high compliance, low vascular resistance, and low afterload. On the contrary, the systemic circulation is of moderate compliance, higher vascular resistance, and higher afterload. During exercise, it's different. The pulmonary circulation and the systemic circulation, both they have to accommodate the rise in the cardiac output, which might be 3 to 5 times the normal resting one. And even it might rise to 40 liters per minute in highly trained athletes. This considerable change in the outflow and the blood circulation, it is accommodated well with the systemic circulation via extensive dilatation of the big vasculature, the large vasculatures, resulting in a marked reduction of vascular resistance and thus a moderate increase in the systemic pressure. But the already low resistant, high compliance pulmonary vasculature, what will it do? It's going to have limited capacity to decrease this vascular resistance and consequently requires increased rise in the pulmonary artery pressure to maintain the increase in the cardiac output. As we can see here, the right ventricle is subjected to a reduction in the systolic function. It might be mild reduction, increase in the size, rise in the biomarkers, and a potential right ventricular fatigue. But we have to consider that the worsening in the right ventricular is transient, and it can be reversed within few days of the exercise, of stopping of exercise. In 2015, there was an initial effort done by the ICAVI to guide us to how to have the proper imaging of the context of the athlete evaluation. And also, it's not only for the imaging, they had further advances in this field, including the new international criteria for the electrocardiogram, the ECG interpretation. And 2018 and in the 220, They mentioned that before doing the imaging, we have to have proper clinical evaluation of each patient about the history and the symptoms. In this evaluation, we have the physiologic determinants, whether the type of the sport, the ethnicity, the body size, the gender, and the age. As we found out that the changes in the male gender is much more pronounced than the females, we have to consider the body size as well. The black ones are having more pronounced hypertrophy of the ventricles than the white ones. With the family history, we have to find out to look for the unexpected or sudden cardiac death in the adults, I mean less than 50 years, and also in the infants with this syndrome. Or unexpected car accidents, this might mean that there is arrhythmogenic heart syndrome. As I mentioned, the sport type differs from one to another. These are the isometric ones, and this is the isotonic. The isotonic ones having more pronounced cardiac remodeling than the isometric. So we have to consider which type of the athlete is doing. So the first handy thing in imaging is the echocardiography. The two-dimensional echocardiography is usually the first thing to be done. But before doing this study, the athlete should be well hydrated, and he should stop the exercise 6 hours before the examination. His body surface area should be considered, and the sex as well should be considered in evaluating the exercise-induced right ventricular remodeling. Also, we have to do the focused RV views, not the regular views. Physiologically, there is harmonic, there is equal enlargement of the 4 cardiac chambers. This is the normal adaptation. Also, there might be a slight reduction in the right ventricular global function. And the regional function is always preserved. I don't have segmental difference. This is the physiology. But in the pathological one, we have the right ventricle is pronouncedly dilated, disproportionate of the adaptation. A ratio, as we can see here, a ratio of the right ventricular inflow dimension in the 4-chamber view related to the dimension of the end-diastolic dimension of the left ventricle in the long axis view. This ratio should be less than 9. If it is more than 9, this is pathological and not physiologic adaptation. As well, the right ventricular dimensions, we don't say it's only dilated and that's it. No, we have to measure it in the long axis view. It's more than 90 millimeters per meter squared. That's why we have to have the body surface area to induce every dimension we are having. The same thing in the short axis, it's going to be more than 21 millimeters per meter squared. If we find that we have regional wall motion abnormalities, then this is considered to be abnormal, and this is not a physiologic adaptation. Of course, we are having different varieties of the two-dimensional echo measurements. And since we have different measurements, we don't have a gold standard. This means that. So we have, and no one of them is equivalent to what we have by the CMR. We have major challenges for right ventricular assessment by the conventional 2D echo. First of all, the complexity and the asymmetrical geometry of this ventricle. It is severely trabeculated from the inner side, and we cannot see or visualize the endocardium definitely. Something very important that we cannot from one view get the inflow and the outflow of the right ventricle in the same view. This is very cumbersome for the operator. And it is a load dependency ventricle, so it makes the changes of the pressures in particular different. So when do we exercise echo? Typically it's indicated in the detection of coronary artery disease, but in some elite endurance athletes, both the left ventricle and the right ventricle dilatation report to be associated with mild impairment of the systolic function. And if we do the exercise test and the systolic functions improve later on, then this is a physiologic. So we can measure the contractile reserve by this phenomenon. Other novel echocardiographic techniques, the speckle tracking and the 3-dimensional echo, are not part of the routine evaluation of the athlete according to the guidelines. The strain and strain rate imaging are able to objectively quantify the regional right ventricular dysfunction, and if this happens, this is a pathological and not a physiological thing. However, studies investigating the right ventricle function in athletes by strain and strain rate remain limited. The studies are limited, and we don't have a cutoff value, universal accepted cutoff value. But there are consensus for the global right ventricular strain, and this consensus that we use them, and we have a cutoff value for differentiating physiologic from pathologic by minus 20%. If we have more than this minus 20%, then this is a pathological one. In addition, if we have presence of mechanical dispersion of the right ventricular contraction, this is again unhealthy. As you can see here, this is a normal one. It's minus 28, but when it comes to minus 10, this is abnormal and pathological. What about the 3G echocardiography? Again, as I mentioned, this is not the routine, but it should be used when we are in a mess, especially after the advancement of the machines and the software of the 3G. We have a particular software for the right ventricle. As you can see, this is the free wall surface, and this is the septal surface. Each one is confined of 4 parts: inflow, outflow, body, and apex. As I mentioned, by the 2G, I cannot get them together, but by the 3G, I can get them together in one view. The 3G reconstruction doesn't require geometrical assumption, which is used by the 2G echo, based on a standard, and not based on standardized views. But we have the dimensions we get, and it's comparative to that of the magnetic resonance and the radionuclide ventriculography. So it is very good for the follow-up of the patients. So we don't do every time we do CMR. This is good for the follow-up of the uncertain patients. What about the CMR? It is currently the standard and the gold standard view. The gold standard technique, it's due to spectral resolution and the 3G capacity. However, it has the disadvantage as everything. It doesn't have all merits. It has disadvantage of being patients might have, or the subjects might have claustrophobia or implanted metallic devices. طبعا ده كان زمان، إن دلوقتي metallic devices are friendly with the CMR. The cost, it is very costly. The long scan and analysis time, and the limited availability and dedicated expertise. Cardiac computed tomography is still in the guidelines. It is not the required thing, because we usually do it for, it gives good measurements for the global ventricular function, but usually we use it for those with the coronary artery disease. And it shouldn't be the first choice imaging for athletes. Here, this is how it goes. First of all, we do the ECG. If it is normal, then okay, this is a physiologic adaptation. If it is not normal, we have arrhythmias, then we go to the second step of the echo measurements, the regular ones. If it is okay, then he's normal. If it is upper limit of values or abnormal values, then we go to the third step, as we mentioned, to do the left ventricle to the right ventricular ratio and the wall thickness, and that's it. If it is inconclusive, then we go to the exercise, to the CMR, and to the ambulatory ECG. I have a case like this. This is a 61-year-old gentleman, competitive cyclist for more than 40 years of uninterrupted high-intensity endurance training. He was asymptomatic, very important. He's asymptomatic with negative family history for cardiomyopathy or sudden cardiac death. On the resting ECG, it showed an incomplete right bundle branch block. Incomplete right bundle branch block, and with exercise he has just 3 beats of left bundle branch block of non-sustained VT. The echocardiography revealed a significantly dilated right ventricle, and as this is 46. This is too much, and the long axis, the right ventricle in the long axis was 22 millimeters per meter squared. The basal diameter 46. And the global systolic function of the right ventricle was normal with a fractional area change of 44, which is normal, and no evidence of regional wall motion abnormality. His cardiac magnetic resonance confined marked dilatation. The RV to the LV ratio was 1.2, which is more than the 0.9 we mentioned before, but we had no areas of late gadolinium enhancement detected for both ventricles. So in this patient, this athlete, what are we going to consider? He is asymptomatic. He had a negative family history. Imaging showed that he had a significant right ventricular dilatation, but still it was not conclusive of being a pathological adaptation. So this one was considered a periodical follow-up every 6 months was advised for him because this was not pathological adaptation. Thank you very much.
شكرا يا دكتورة عزة. هو سؤال بسيط، احنا قلنا CMR هيبقى مور سوبيريور للكل،
ده الجولد ستاندرد
تماما. قلنا الايكو كارديوجرافي ده ذا مور وايدلي ابليكابل تول في كلنا بنستخدمه.
ده 2D، لكن لما دخلنا بقى ال 3D والسبيكل تراكنج الحقيقه الامور اختلفت.
بس سبيكل تراكنج ستيل ليميتد يوز لغايه دلوقتي يعني.
هو الجلوبال
هو طبعا عشان تقولي رايت فنتريكولار فانكشن بي طبعا ده احسن واكيوريت عن اي حاجه، لكن ستيل ليميتد يوز وليميتد ستاديز.
ما هو عشان كده هنعمل سelection حضرتك، يعني نفضل نمشي بالالجوريثم كل واحده لما نلاقي، لكن مش اول ما الاقي الدايليتد رايت فنتريكل اقوم موديها على طول على CMR.
تمام. في حاجه بقى انت اشرت لها في الاول، قلت اللي احنا بنشوف الفسيولوجيكال ادابتيشن والكلام ده وكان ريجارد بالبايوكيميكال ماركرز. ايه هي الماركرز اللي ممكن تقول لنا ان الرايت فنتريكل از جيتنج؟
بنلاقي التروبونين بيبقى عالي ده مع
لكن ما فيش اي سبيسيفيك.
لا ما فيش حاجه سبيسيفيك.
Thank you, Dr. Azza, for this elegant lecture. I want to ask that you mentioned that this occur in athlete patients, so it will take a long time to occur.
Athlete subjects.
Athlete subjects, yes.
So
So it will take a long time to occur.
Yes, exactly.
If there is any adaptation before this dilatation and decrease of this function, I suppose that in athlete heart, LV start to be hypertrophied first and dilated, then it will happen that there decrease function.
Yes.
Is the right ventricle the same?
Yes, it starts. Dysfunction ده بيبقى في الآخر.
في الآخر خالص.
من كتر الانديورنس يعني مش في كل مش في الواحد بيلعب جولف هيحصل ده.
So there is stages for this to occur.
And it depends again on the type of exercise he's doing.
Yeah.
يعني playing golf this is isometric مش هيعمل ده خالص. الرايت ventricle dilatation بيحصل مع الايزوتونيك اللي هم السايكلينج والباسكت بول بلاير سوكر بلاير الحاجات دي، لكن التانيين اللي هو ويت ليفتنج ما بيحصلش معاه كده. فهو الستارت هو الدايلاتيشن وان الفنتريكل تكبر والرايت سايد كله يكبر، وبرده لازم يبقى بالريشيو اللي احنا قلنا عليها علشان يبقى كده. لكن مش كل الناس بيحصل لها impairment of systolic function، وزي ما بقول لحضرتك لما بنعمل exercise it is reversed، الكارديو ريزيرف بيتحسن.
Thank you, Dr.
الكاردياك ريزيرف.
دكتورة عزة حضرتك في الستيب وايز ابروتش بتقولي ECG نورمال ات مينز يعني لو في فيرست ديجري هارت بلوك او 2 to 1 او
لا 2 to 1 ده مختلف. 2 to 1
لا ما هو اصل نورمال بنشوفه في الرياضيين نقول ده نورمال يعني لا مش 2 to 1 يعني في سكند ديجري.
واحنا ممكن نلاقي عندهم حضرتك
كلمة نورمال يعني نورمال ما فيش أي ديجري في هارت بلوك ولا؟
لا ما فيش بلوكس، لكن لما يبقى في بريماتشورز this is accepted، لما حتى النون سستيند رانز دي ممكن الاقيها accept، وحتى البراديكارديا طبعا بيبقوا عندهم براديكارديا depends على amount of exercise.
طب حضرتك بتقولي في المحاضرة دلوقتي إن الار في تشينجز ريفرسبل أما نبطل الاكسرسايز، طب ما هو الرياضة ده بيعمل اكسرسايز على طول يعني هل هتظل التشينجز ده؟ ما هو رياضي يعني مش بيعمل اكسرسايز ويبطل.
ما هي الفكره ريفرسبل اور نوت. لو مش ريفرسبل ده فيها كلام، نبتدي بقى نراجع نفسنا في ان احنا قلنا عليه ايه. ما هو عشان كده هنعمل قبل ما نعمل الايكو هخليه يبطل الاكسرسايز 6 hours، ده مش قصه يعني. وحتى الحاجات الثانيه دي few days، حتى لو لقينا بقى impairment of systolic function few days لو ما كانت مش it's not reversed then we should consider this pathological and not physiological.
شكرا.
I have a question. Thank you very much, Professor Azza.
حاجة مش مطروقة بس.
Fantastic presentation. And this indicates that RV is a forgotten chamber.
It's no more بقى ده. ال 3D عامل dedicated software for the right ventricle, which is very important now.
If we have a child with dilated right ventricle with normal RV systolic function, so is it allowed for exercise, for
على حسب سنه ممكن.
dilated ventricle.
Yes, dilated ventricle.
Yeah. Our right ventricle is
yes,
dilated.
I understand. بس ليه؟ يعني is he an athlete ولا he's not an athlete? He's not an athlete.
Yeah.
لا, I have to search vigorously
Yeah.
for ASD. I have to search for partial anonymous pulmonary venous drainage. I have to search for coarctation of the aorta. علشان ده هيخلي right. I have to. If I don't have anything في يعني congenital anomaly, I will subject him transesophageal عشان أتأكد إن ما عنديش ASD.
Yeah. Or CMR before
لا, transesophageal first. It is cheaper
first.
and easier for us.
Yeah.
يعني ده أسهل للعيان لأن التشايلد عشان أحطه على CMR ما أنا هنيمه برضه لأنه مش هيستحمل الكلوستروفوبيا والقعدة دي. It's not that we have to do anesthesia.
Great.
Thank you, Dr. Azza. Now to shift to the second speaker, Dr. Azza Farag, Cairo University. She will discuss the multimodality imaging in heart failure with preserved ejection fraction.
Thank you very much, Mr. Chairman. الحقيقة أولاً أحب أشكر دكتور مجدي for inviting me for this prestigious meeting. الحقيقة دكتور مجدي is my professor, my colleague, my boss in Cairo University, كل حاجة. يمكن my talk about the multimodality imaging in heart failure with preserved ejection fraction is more simple than the talk of Dr. Azza Al-Fiqi. يمكن دي more common. We face it every day in our clinical practice, and we must know how to differentiate between actual heart failure with preserved ejection fraction and symptoms mimic heart failure with a patient with reduced functional capacity. So, first of all, I want to clarify that heart failure with preserved ejection fraction is a clinical syndrome. It is not an echocardiographic diagnosis. It is a clinical syndrome defined by the presence of the following. First of all, from the title, being heart failure, we must have heart failure symptoms or signs, whether it is left-sided or combined left-sided and right-sided. Sometimes we have some increase in certain lab, like the natriuretic peptides. We have, because of preserved ejection fraction, we have ejection fraction of about 50 or more, despite the fact that, like Dr. Azza Al-Fiqi said, that sometimes you have normal ejection fraction or preserved ejection fraction, and the different recent echo modalities can clarify that the ejection fraction is not actually preserved, like the strain. We have some specific structure alterations in the ventricle we image in our patients, and definitely we have various degrees of diastolic dysfunction, like the impaired relaxation, the pseudonormal, and the restrictive pattern. Why we are talking about heart failure with preserved ejection fraction? Actually, it now represents about 50 or more % of the cases of heart failure. And it is now the most common cause of heart failure, mainly in patients aged 65 years or more. It's expected to be the most prevalent form of heart failure in the next few years. And actually, the prevalence of this clinical syndrome in comparison to the HFrEF is increasing at a rate of 1% per year. This means that within 10 years, the prevalence of HFpEF increased 10%. Actually, the story is not just you have HFpEF and you have comorbidities for the HFpEF, but actually it is now we have the more sophisticated imaging techniques to clarify that the patient already has HFpEF. So HFpEF is more common in older age, in women, in multiple risk factors like many comorbidities like obesity, type 2 diabetes, hypertension, chronic kidney disease, sleep disorders, and so on. Patients with HFpEF and atrial fibrillation, which is very common because most of our studies and trials regarding diastolic function and diastolic indices actually exclude patients with atrial fibrillation to get more or less a proper results. So patients with HFpEF and atrial fibrillation actually do worse than patients with HFpEF and normal sinus rhythm. What about the pathophysiology of HFpEF in general? I don't go through multiple lists, but if you notice these pathophysiology parameters, you can find out and clarify the underlying problem in the pathology. You have increased systemic vascular resistance, like in patients with hypertension, increased conduit arterial stiffness, abnormal ventricular arterial coupling, reduced left ventricular long axis systolic function, slow early diastolic relaxation as one of the parameters for diastolic dysfunction, reduced ventricular compliance, increased in diastolic stiffness, and of course, which is very important, is the role of left atrium kinetics in diastolic function assessment. If you look to this figure, all are going into one pathophysiology, which is increase in left ventricular filling pressure. Either you have impaired relaxation of the ventricle, either you have increased diastolic stiffness, or loss of restoring force of suction. I will tell you about this parameter, which is very important in the recent practice, in the recent research, which is the negative suction for the left ventricle. All leads to increased left ventricular filling pressure. So we came to the main target of this lecture, how to assess a patient with left ventricular preserved ejection fraction and his symptoms highly suggestive of heart failure. This is a score. We have a lot of scores, but this is the most recent and the most palatable and the most easier score for assessment of heart failure with preserved ejection fraction. Because it is a so crowded study, so we clarify these steps in a separate slides. So first of all, step one is the initial overview. You must have a good history and good examination of your patient. It is not to jump directly to imaging techniques or whatever. It is echocardiography because it is easy and easy have easy access in most of our labs. Start with physical examination and good history to know the risk factors and the associated comorbidities. And then illustrate very clearly the symptoms and signs of heart failure. Sometimes you have an obese patient, you have a patient with low physical fitness, and patients with some comorbidities, and sometimes also arthritis or whatever. And he has symptoms of shortness of breath, he has symptoms of fatigue, she has symptoms of being overweight and sleepy most of the times. These are not symptoms of heart failure. So you must clarify if your patient's symptoms is really related to being heart failure with preserved ejection fraction or not. Rule out any other non-cardiac condition and make your standard diagnostic techniques. Start with electrocardiogram, standard echo. If you have the facility to perform natriuretic peptide, it is very helpful. And make a very simple test, which is the 6-minute walk test, to clarify the functional status and the functional capacity of your patients. And then you move to step 2 if you have nothing to declare or nothing to find abnormal in your first step. If you notice that your first step is normal, move to the next step, which is first echocardiographic scoring. By echocardiographic scoring, we have major criteria and we have minor criteria. The major criteria are the most famous four pillars of treating heart failure with reduced ejection fraction. We have 4 items to be fulfilled. 3 of them called the functional domain, and 1 is the morphological domain. The functional domain starts with tissue Doppler analysis of the septal site and the lateral side of the mitral annulus. By the way, we don't have multiple annuli. You have one mitral annulus. So we have the septal side or the medial side and have the lateral side. So if you have a value of 7 centimeter per second of the E, which is the early filling velocity or early myocardial velocity at the septal site, in 10, so you don't have anything. But if you have figures below these values, 7 and 10 at the septal and the lateral side of the mitral annulus, you have 1 point of your calculating score. The second is the parameters related to left ventricular filling. as you know, the pulmonary capillary wedge pressure cannot be assessed directly by non-invasive technique, but you can take a global overview about the pulmonary capillary wedge pressure if you measure the E mitral velocity over the myocardial E velocity. If it exceeds 14 or sometimes it reaches 15, according to other references, you have increased left ventricular filling pressure, and so you have the second point. If you measure the tricuspid regurgitation velocity and you find that it is more than 2.8 meter per second, and this calculated at 35 millimeter mercury of pulmonary arterial pressure if you do not have any obstruction to the pulmonary flow, so you have the third point. These are the three functional domains to assess HFpEF. The fourth one is the parameter related to left ventricular remodeling. Now it is considered the left atrium. If you measure the left atrial volume, either by Simpson or by area length method or whatever, at its maximum chamber area, and you find that the left atrial volume indexed to the body surface area is more than 34, so you have the fourth point. Sometimes you have some minor criteria like the left ventricular mass index. It is different from male and female in the relative wall technique. This is an example for a normal subject and a patient with left ventricular hypertrophy. Of course, you have diastolic dysfunction with impaired filling by either myocardial velocity or the conventional Doppler velocity. We got our major criteria. We have another minor criteria by echocardiography. The global left ventricular strain less than 16%. This is considered one of the minor criteria, and the left atrial reservoir strain less than 18. Reservoir means that we take the area at the largest volume of the left atrium, which at the end systole. Here, the end of T by the ECG at the end systole. Again, we have in step 2, in addition to the echocardiographic scoring, whether it is major or minor, we have biomarker scoring. We have either major criteria by measuring the pro-BNP more than 220 if the patient is in normal sinus rhythm, or the BNP itself, not the pro-BNP, of 80 in the normal sinus rhythm. And if the patient has atrial fibrillation, to know how much it is risky, you multiply this by 3. So the 220 became 660, and the BNP itself became 240 in patients with atrial fibrillation. So the minor criteria with the biomarker scoring is lesser than these values. Now we can collect our major and minor criteria are scored with 2 for the major and 1 for the minor. If you collect 5 points or more, you have definite diagnosis of heart failure with preserved ejection. And I will remind you again, in the presence of symptoms and signs of heart failure, not just diastolic dysfunction. If you have 0 or 1, this is normal. And now we have the gray zone between 2 and 4 points. This is uncertain diagnosis of HFpEF. If we got this uncertainty, you must have moved to the third step, which is the functional testing in case of uncertainty, which is called the diastolic stress test. The aim of the diastolic stress test is to detect left ventricular diastolic reserve impairment, which leads to increase left ventricular filling pressure during exercise. Look at this figure. You have 2 subjects. One is normal, which is subject A. He can achieve more cardiac index with a lower pulmonary capillary wedge pressure elevation, but in patient B, it is not a normal subject. He achieved a lower cardiac index at a higher degree of pulmonary capillary wedge pressure. This is the test, how to perform the diastolic stress testing. It is totally different than the systolic stress testing. The diastolic stress testing must be on supine bicycle ergometer. I don't know if any center in Egypt has a supine bicycle ergometer, but we are waiting for our machine in our lab by the end of this year. We cannot make dobutamine stress echo because dobutamine stress echo increase the heart rate markedly, and here we are focusing on the waves to assess the diastolic stress test. So what we are doing by exercise diastolic stress testing, we make mitral inflow, evaluate the mitral inflow, the myocardial velocity, the tricuspid regurgitation velocity, and we make our image acquisition at rest at end of each stage of physical exercise and at recovery. So look at this. Here we have a normal subject. He has stressed by 25 workload, 50, and each time we have increase in the early filling velocity and late diastolic velocity, and this was associated with concomitant increase in the same velocities on the myocardial level. But here we have some increase, lesser increase in the mitral inflow velocity, but with blunted response in the myocardial velocity. To be sure that this is a normal or a diastolic stress that can be readable and attributable, and you must have clear distinction between the waves you are assessing. Again, here a patient, the same patient, have increase in the tricuspid regurgitation velocity at a higher workload. This is a normal person, which is the patient A, but in patient B, we reach the 4 meters per second at a lower workload in comparison to the last one. So what about the limitation of exercise stress tests? Fusion of the E and A waves of the mitral inflow when the heart rate exceeding 100 and 110. So because of this, we cannot use the butamine. Here are the illustration for every minute you can increase your workload to reach your target of 110 millimeter mercury. So invasive, 110 beat per second, per minute. Invasive hemodynamic measurements is very important because if you increase the end-diastolic pressure with exercise, this means that the patient has already some impairment of his diastolic function. What about the other imaging modality? The other imaging modality actually has a role when you got to step 4, when you want to clarify the underlying pathology of your patient, why he has heart failure with preserved ejection fraction. Either we use the echo, which can illustrate any valvular lesion, any precordial disease, any other abnormal pathologies that cause left ventricular hypertrophy, for example, and computed tomography to clarify the presence of coronary artery disease or something like constrictive pericarditis and extensive calcification. Cardiac magnetic resonance and nuclear imaging can clarify certain categories of patients like the amyloidosis. Here, cardiac magnetic resonance can clarify the morphology, the systolic and diastolic function assessment, in addition to the tissue characterization and, of course, the delayed hyper-enhancement technique. Here by CT, the coronary artery disease, the pericardial calcification, and any other pathologies. And, of course, as I said, the nuclear imaging and the PET scanning can be the most relevant for detection of ATTR amyloidosis, which is a famous pathologists nowadays all or most of references talk about. What about the future perspective? Here it's a very important point. Recently it was shown that absence of a decrease in minimal left ventricular pressure during exercise, a manifestation of impaired LV suction, was closely linked with impaired left ventricular untwisting during exercise. To clarify this paragraph, we all know that contraction of the left ventricle is not like this. It is mainly the base toward the apex, and the contribution of the apex is very minimal. So we have longitudinal function of the heart, either expressed at the MAPC or the global longitudinal strain. So again, what's called twisting or untwisting, or the rotation movement of the left ventricle, is like this. When we rotate the heart, or with joint contraction, the base of the heart moves anti-clockwise and the apex moves clockwise. Before doing this, which is the reverse, is the diastole, the base is clockwise and the apex is anti-clockwise, you must have some degree of suction. If you miss this suction because of elevated left ventricular minimal diastolic pressure, you have abnormality in the hemodynamics and abnormality of the kinetics of the left ventricle. So patients with decrease in minimum left ventricular diastolic pressure had most marked increase in the left ventricular untwisting. Twisting is systolic phenomena, and untwisting is a diastolic phenomena. So if you miss this minimal decrease in left ventricular and the diastolic pressure, you have defect in the untwisting, in the diastolic function of the heart. Patients with normal ejection fraction previously treated for being ischemic heart disease either by intervention or by surgery, it was shown a range of response when measuring minimum left ventricular diastolic pressure and untwisting velocity. Here is an illustration for this. Now, 1 minute. My last. Here an illustration for this. If we have positive suction means that we have maintained the left ventricular and the diastolic pressure and the minimal suction. We have some degree in the minimal left ventricular, and so we have increase in the apical untwisting, but the reverse is right. So my take-home message is that heart failure with preserving ejection fraction represents a challenging clinical syndrome. Again, it is a clinical syndrome. It is not an imaging technique, despite the fact that considerable progress is being made in its overall framing. The diagnosis of HFpEF relies mainly on increased left ventricular filling pressure. This is the main clue. This is the key, is increased left ventricular filling pressure, which can be non-invasively determined by echocardiography to a great extent. It's not 100%, but to a great extent. It is pivotal to follow the appropriate diagnostic pathway starting from clinical examination and history-taking, laboratory, and different imaging modality conjoined together. Thank you very much.
Thank you, Dr. Azza, for this excellent lecture. And if there is any question from the floor.
Dr. Azza, thank you very much. Excellent presentation. أنا not expert in echo، لكن بأمانة أنا استفدت جدا من المحاضرة بتاعتك. بس اللي لفت نظر أكتر الدياستوليك ستريس ايكو. يعني هو انت قلتي لازم تبقى فيزيكال اكسرسايز، ما ينفعش نوتروبيك فارماكولوجيكال. رغم انا شايف ان الفكره كلها ان الهارت ريت بيزيد والكونتراكتيلتي بتزيد. صح. هل لو ادينا حاجه زي الدوبيتامين ما يعملش الكلام دوت، ولا هيأثر على الانتويستنج افكت بتاع الدايستول؟
لا، هو مش هيأثر.
انت برضه خدتينا في سكه
لا لا لا، هو مش هيأثر على التويست. هي كل الكونسبت انت حضرتك you cannot predict which heart rate you can achieve by dobutamine. Even if you start with a very small dose, you cannot predict how much is the heart rate you can achieve. You must to clarify the waves, and they will be very distinct from each other to know which of them is increasing and which of them have a blunted effect. You must have a heart rate of 100, 110 maximum. يعني if you increase more than this, you cannot read the test.
يعني معنى كده الفيزيكال اكسرسايز انت عندك ليميتد هارت ريت هتوصلي له عشان توصلي لكل البارامترز اللي انت عاوزاها، سواء بالتيشو دوبلر او
بالسوباين باسكي ergometer. The patient is lying down and he make a pedal with his legs. That's all.
يعني هو الليميتيشن ان انت you cannot predict الهارت ريت اللي هتشتغل ايه عشان توصل للبارامترز.
لان انا هنا مش ببص على وول موشن abnormalities.
ما انا واخد بالي، انا ببص ان انا بزود كونتراكتيلتي وهارت ريت واشوف الدايستوليك فانكشن بالتيشو دوبلر وبالترانس مايترال فلو في الفتره دي. اوكي.
It is the same parameters I look for during diastolic stress test. It is the same parameter I looked for with the rest echocardiogram. But because I cannot achieve the scoring points that I want to be my target for diagnosing the patient is HFpEF, so I must make some sort of clarifying the diastolic reserve by the same parameters. If I achieve this during exercise, so it is diagnosed as HFpEF.
Okay, thanks.
دكتور عزة، هو بس تويست ان تويست طول عمرنا بنعلق على الوول موشن ابنورماليتيز بال2 دي او ال3 دي. هل انا بشوفه بالاي بولينج ولا يعني ده؟
لا، هي ما تتشافش باي اي بولينج يا دكتور ايسر. هي في يمكن الدكتوره عزه يعني تشاركني الراي ان هم في سوفت ويرز، بس هي مش موجوده. انا ما شفتش ولا واحد في الفندرز اللي عندنا، بس في سوفت ويرز most of them for research purposes بتكلاريفاي الديجري اوف تويست اند انتويست. تويست is a systolic phenomena, untwist is a diastolic phenomena. Twist means that هي في الفكرة كلها لما بتيجي تتصور كأنك بتعصر فوطة. فهي الفكرة كلها إن العصر كده ده diastolic. أنت لازم تبقى anti clockwise for the base during systole. هنحفظ واحدة بس. The base is moving anti clockwise during systole. الapex العكس. During diastole هيحصل العكس، إن البيز هتموف clockwise in the apex. كل القصة ايه؟ ان during this twisting to get the function very properly, whatever systolic or diastolic, you must have some degree of negative suction before doing this twist. لو شفنا هارت بيتحرك كموديل او يعني الهارت طبيعي، لو شفته على الويب سايت هارت بتاع ضفدعه مثلا، هتلاقي ان المساله كلها كل الناس متخيله ان الهارت بيكونتراكت كده. هو مش بيكونتراكت كده، هو mainly based toward the apex الكونتريبيوشن. عشان كده لما في الفور دي احنا بنبقى عندنا 16 or 17 segment. ال 17 segment is the additional apical cap. أنا عندي 16 segment additional. Most studies and most trials discard this apical cap because the contribution of apex is very many. Mainly you have base to apex movement. In addition to the base to apex, you have the twist and untwist. During contraction, the heart twisted and untwisted. علشان proper diastolic function to be maintained, you must have some degree of negative suction before. وده بيبان في left ventricular tracing invasively إن أنت بتنزل below the zero line during diastole. This is normal. If you don't below the zero line, it's above the zero line, so you have some degree of elevated left ventricular diastolic pressure and the diastolic pressure.
I have a question. Thank you very much, Dr. Azza. Excellent presentation as usual. You addressed a very important and challenging topic, which is HFpEF, which is underdiagnosed. And in the daily practice, we are seeing a lot of patients like obese, elderly, hypertensive, shortness of breath. وتلاقي في الإيكو dilated left atrium, pulmonary artery pressure 40, ويقول لك diastolic dysfunction. So how to improve the diagnosis of HFpEF, because the echocardiographer are not all are experts like you and Professor Azza, Professor Gamila. So how can reach to a unified criteria for diagnosis of HFpEF, which is common?
Okay.
But unfortunately, the echo reports are misleading, are not, yeah.
طيب السؤال بتاع الدكتور مجدي الحقيقه هو very practical، وهو يعني سؤال مهم جدا، وهو الهدف من ماي توك. هو very practical. احنا بيجي لنا عيانين كتير قوي في العياده، سواء العيادات البرايفت او في عيادات المستشفيات. Patients coming with symptoms, as I said before starting my lecture, mimic heart failure. Symptoms mimic. They have reduced functional capacity. Obesity is very prevalent مثلا في بلدنا، خصوصا in females. تلاقي الست تخينه قوي وهي جايه بتلقف بتنهج، هي مش قادره تعمل اي حاجه. هي لما بترد على التليفون بتلاقي صوتها كانها بتجري. انت you want to clarify if this symptoms of the patient, especially if the patient has normal ejection fraction more than 50%, this is related to heart failure with preserved ejection fraction or just it is a functional symptom. So you have a scoring system. الايكو موجود دلوقتي في كل الاماكن، وكل الماشينز من اكتر من 10 سنين لحد النهارده فيها تيشو دوبلر. يعني البيزك ايكو ماشين من غير اني اذر سوفت وير فيها تيشو دوبلر. كل الفكره ان انت عايز تعود الناس، ويمكن احنا برضو الدكتور مجدي عارف ان احنا بنسعى دلوقتي ان احنا نعمل، والدكتوره عزه طبعا كانت مشتركه معانا في اليونيفايد ايكو ريبورت. احنا بنعمل يونيفايد ايكو ريبورت للقصر العيني ان في parameters معينه should be fulfilled routinely. البارامترز دي ما هياش صعبه، ما هياش تايم كونسيومينج، مش هتاخد وقت، مش محتاجه ماشين مخصوصه، مش محتاجه a lot of experience. ان انت تاخد السبتال واللاترال فيلوسيتي، انت اوريدي بتاخد الميترال انفلو فيلوسيتي. انا كده عندي 2 بوينتس من الاربعه الميجر باي ايكو كارديوجرافي. روتينلي كل الناس بتعمل تريكاسبيد ريجرجيتيشن فيلوسيتي. بلاش نعبر عنها ب pulmonary artery systolic pressure، لأن pulmonary artery systolic pressure أنت assess the right atrial pressure من inferior vena cava وجمعته على ال right ventricular systolic pressure. لا، هو بيقول لك tricuspid regurgitation velocity لو أكتر من 2.8 أنت هتعتبر إن ده 1 point. لو السبتال واللاترال قال 7 و10 أقل منهم this is another point. لو الاي فيلوسيتي اللي اتقاست طبيعي من الميترال انفلو اتحطت واتقسمت على الاي فيلوسيتي، يبقى انت عندك 3 بوينتس. اصعب واحده فيهم اللفت اتريال اسسمنت. لو انت عندك سيمسون رول في او سيمسون ميثود في اللفت فنتركل، انت يو كان ابلاي فور ذا ليفت اتريوم ات ذا اند اوف سيستولي. يعني لو حاطط اي سي جي هو الاند اوف تي، لو مش حاطط اي سي جي هو ذا لارجست diameter اوف ذا ليفت اتريوم. الفكره ان انت لو حققت، لو انا استبعدت بقى الناتريوتيك بيبتايد، لو استعملت الايكو بس، لو انا حققت 0 or 1 this is known. لو حققت 4 3 أو 4 this is impaired أو heart failure with preserved ejection fraction. هتبقى المشكلة كلها في نمرة 2 اللي أنت ما أنتش عارف هي فعلا related ل preserved ejection fraction heart failure ولا دي.
طبعا ده مهم لأن النيتريتك بيبتايدز 30% بيبقوا نورمال في الهيف باف،
فبالتالي اللي أنا عايزة بس أقوله كمان مهم قوي، إن يا ريت نتعلم إن إحنا لما يبقى حد بعت لنا عيان فور ايكو ان احنا we do not accept the patient except with referral letter. تبقى عارف الفيزيشن اللي باعت هذا العيان هو عايز ايه. لكن ان انا يجي لي ورقه ان this patient for echo you should not accept. هو لازم زي ما انت هتعمل your homework لازم الفيزيشن او الجراح او وات ايفر اللي باعت لك العيان يدو his homework. هو بيكزامن العيان، بياخد منه شورت هيستوري حتى لو هو مش كارديولوجيست، وبالتالي هو عارف باعت لك العيان ليه. لكن ان انا يجي لي عيان فور ايكو وانا اللي اقعد اخد منه ديتيلد هيستوري واكزامن وبتاع، انا مش هخلص لستي. فهي السؤال اللي بيقوله الدكتور مجدي is very important، ان انت علشان تدور على حاجه لازم تبقى عارفها ولازم تبقى عارف ان انت هترد عليها ازاي. اتفضل دكتور احمد.
اعتقد دي مهمه دكتور عزه بينتها. انا في تخيلي ان فعلا التيشو دوبلر اعتقد بقى اساسي في كل حاجه. انت البرايم اي سيبتال ولاترال هيبقى مور سبيسيفيك عن البالمر ارت على التراكاست بريجاج اعتقد، لان الهيمودايناميك تشانس هايبرفوليميا هايبوفوليميا. يعني ايه راي حضرتك في كده؟ يعني انا لو انا اعتمد اكتر اسسمنت اوف سيبتال لاترال تيشو دوبلر rather than the pulmonary hypertension اللي ممكن يحصل حاجه كتيره ثانيه اخرى.
بص يا دكتور احمد، هو ما اقدرش اقول هعتمد على مين اكتر. هي الجوريزم، هي دايما عارف حضرتك زي ايه؟
يعني اهميته اهم كمان من نشوف.
لا انا هقول لحضرتك بطريقه ابسط. احنا لما بنيجي نيفالويت ستينوتيك ليجن انت ما عندكش سو لونج او سو ماتش بارامترز. انت بتاسس السيفيريتي اوف ستينوزس وات ايفر ذا فالف از اسست باي جريدينت اند اريا. ما عندكش حاجه ثانيه. عندك indirect evidences of left ventricular hypertrophy, left atrium كبير whatever. لكن لما تيجي تأسس regurgitant lesion you have a lot of parameters you should assess to make your proper diagnosis that this is actually a severe mitral regurg or severe aortic. It is the same for diastolic dysfunction. By systolic function you have ejection fraction. Most of our labs depend on ejection fraction in spite of its limitation. اللي عنده امكانيه ان يبقى عنده ejection fraction by 4D او عنده strain هيعملها، لكن اللي ما عندوش احنا بنعتمد على ejection fraction وبنقول ان ده باي سيمسون هيبقى for distorted heart and so and so. لكن الدياستوليك انديسز والمابسي طبعا، لكن الدياستوليك انديسز انا هنا هرجع تاني واقول تاني للتفكير، انا مش بشخص diastolic dysfunction، انا بشخص heart failure with preserved ejection fraction. فالdiastolic indices اللي هي impaired filling reversed A over A ratio او pseudo normal pattern او restrictive pattern cannot give me any clue about that the patient has heart failure. I must collect all data available and I can get it easily from my echocardiographic examination to reach my diagnosis.
كعادتك يا دكتورة عزة انفورماتيف وإليجانت توكس، ربنا يكرمك. وأنا محظوظ إن أنا هقدم، أشكرك طبعا جدا جدا، ومحظوظ إن أنا هقدم مسك الختام أستاذ دكتورة جميلة حبيبة الملايين وذات الجماهيرية الطاغية، أستاذة القلب بالإسماعيلية ورئيسة القسم. اتفضلي يا دكتورة جميلة.
شكرا. أولا أنا بشكر حضرتك على التقديمة وعلى مستر اند مسز تشيرمان، وبعد طبعا انا بشكر اخويا العزيز الدكتور مجدي عبد الحميد اللي دايما الحقيقه له معزه خاصه وتاريخ طويل في جمعيه القلب المصريه. طبعا الموضوع الحقيقه لما انا اكتشفت على الايميجنج سعيده جدا ان احنا من لحظه للحظه بنشوف تقدم كبير جدا في الكارديولوجي ابديتس، وانا حضرت مع حضرتك بدايتها وكانت كل يوم تطور عن اليوم اللي قبليه. طبعا احنا بنتكلم على الاونكولوجي او كارديو اونكولوجي والايميجنج في الكانسر بيشنتس. معروفه طبعا ان في شيرد باثوفيسيولوجيك ميكانيزم بين الكارديوفاسكولار ديزيز والكانسر. الكانسر ده مهم عشان نفهم ايه دور الاثنين مع بعض، الانفلاميشن، السيلولار بروليفريشن وغيره كتير جدا، وفي الاخر كلهم بيعملوا adverse cardiovascular and cancer clinical outcomes. الحقيقه في common shared factors، واحنا عارفين ان احنا الريسك فاكتورز للكرونيك ديزيزز تكاد تكون واحده، فهم واحد، الايجنج، التوباكو، انفكشنز، دايت، كلها. دي سلايد مهمه جدا لانها بتبين قد ايه الكومبوزيت كوموربيديتي مع كانسر بيشنتس، ويمكن اكثرها الهايبرتنشن زي ما احنا شايفين وغيره. اذا دايما العيان اللي عنده كانسر بيبقى كوموربيدلي افكتد، ما تبقاش حاجه واحده. Crude incidence of overall cancer and major cardiovascular disease by age definitely. We do have a very nice figure showing that the major cardiovascular disease are really increasing, whereas the cancer is increasing, which is really very hazardous. I do have the honor to have my presentation today about the imaging of cancer patients. Important observations. First, survivors of most cancer had increased risk of 1 or 2 cardiovascular outcome. Next, the pattern is varied by the cancer site and its calcification. There is an increase of thrombosis, VTE. There is increased rate of risk of heart failure by 50% in patient survivors. The risk of cardiovascular disease outcome, including stroke, were doubled in cancer survivors, especially hematologic malignancies. The type and dose of the chemotherapy play an important driver for cardiovascular complications. Next, there is an increased prevalence of conventional risk factors, increased incidence of another primary neoplasm. There is increased incidence of viral myocarditis, so increased incidence of hypertension, as we all know. Pulmonary hypertension, of course, the increased incidence of DVT, and the late cardiac toxicity of cancer treatments. These are all problems in patients with cancer, and so it's very difficult to look for the imaging in these patients. Of course, we do have a lot of complications of the cardiovascular of cancer treatment: heart failure, cardiomyopathies, arterial hypertension, coronary heart disease, arrhythmias, myocarditis, QT prolongation, valvular heart disease, pericardial effusion, constriction, and pulmonary hypertension are all complications of cardiovascular complications of cancer treatment. And should I think it's just you have a collaboration between the oncologist and cardiologist looking for the risk cardiotoxicity, risk stratification, monitoring plan, cardioprotective treatment plan, decision to continue, interrupt, or restore the cancer treatment, and recommendation for long-term surveillance. We have risk factors. We all know current myocardial disease, cardiovascular demographic risk factors. We have the lifestyle risk factors, the cardiotoxic antineoplastic treatment, and so. Imaging of the cancer patient. I have just to start by the lab, and this is one of them, the troponin, as we all know, and this is not my mission today, and the imaging tests like ECG, the echo, the cardiac magnetic resonance, and the multi-slice CT, angiography, and procedures. We have the endomyocardial biopsy as well as coronary angiography. So this is really a very important, and this is how general principles of cardiotoxicity imaging. You look for the measure for the 3D left ventricular ejection fraction. You look for the 2D left ejection fraction Simpson biplane. You look for the measure the volumes of the left ventricle. Consider resonance, magnetic resonance, and CMR in some cases. We have to look combine clinical biochemical data, biomarker, measure blood pressure during echo, and measure the GLS. Non-invasive imaging. It is accurate, reproducible. We have the 3D echo, the CMR, the multi-gated, the MAGA scanning provide quantitative volumetric analysis. This is one of the nuclear cardiology techniques, as we all know, with superior accuracy and serial reproducibility. And of course, we do have the quantitative 2D echo using the Simpson biplane method is the most appropriate method, with 3D echo and CMR are not routinely available. As we all know, in the whole country, there is no available, we do have the availability of Simpson biplane method quantitative 2D echo will be available everywhere in Egypt. What about the echo contrast? The echo contrast agents are helpful whenever the endocardial definition is inadequate with routine imaging. And the most appropriate modality will vary with patient characteristics as well as the center availability and local expertise. But I have to say, very important item, when you are dealing with a cancer patient, there is, due to variability of the technique, you have to use the same technique should be utilized to follow up the patient, and this minimize the technique variability. It's really very important. So myocardial deformation imaging, it can early detect and you see, and it can show the subclinical cardiac dysfunction. It provides reassurance. Of course, the reduced GLS is the predictive of anthracycline-based cardiotoxicity 3 to 6 months later, and this may represent a window of opportunity to initiate cardioprotective therapy, as we all know, like ACE and ARBs before the development of reduced ejection fraction, which occurs in 6 to 8% of anthracycline-treated patients. Definitions of cardiotoxicity, as we all know, this is the normal function, as we all know, and decrease less than 50 with abnormal markers, and less than 40 to 50 this is maybe the moderate, and when you go to less than 40, this is severe, and eventually leads to very severe form. Actually, there is a difference in published definitions of cardiotoxicity, and this was found through out the different publications. So the European, and so it's different. It's not, but it just ranges from 50 to 53 to 55, 55%, 50. The reduction 10%, and then one in the ESMO, this is more than 5%. So this is really a little bit different according dysfunction. What is absolute anti-cancer therapy related cardiac dysfunction? Absolute decrease in more than 20 percentage point, absolute decrease more than 10 to a value of less than 50, absolute decrease in function to a value of less than 50. Subclinical relative decrease from baseline in GLS more than 12%, and troponin elevation. What about the new guidelines in the year 2022? What did it say? Of course, we all know all this. And I have said that is a severe reduction less than 40, moderate, as we can see, I've seen before. What about the myocarditis? This is by CMR, and for acute myocarditis by a modified Liklois criteria. First modality for imaging a cancer patient is ECG. ECG is recommended in all patients starting cancer therapy as a part of their baseline cardiovascular risk assessment. So if it is abnormal, you can refer to a cardiologist. This is next point. What about, what can you see in the ECG of a patient? Bradycardia, sinus tachycardia, and the anthracycline. It differs according, as I said, the type of anti-cancer, AV block, conduction disturbances, AF, supraventricular tachycardia, ventricular tachycardia, sudden cardiac death. According, really a difference. But I say very important that you at the baseline, you should, including measurement of the heart rate is important, as well as the QT, corrected QT. This is the most important slide. I'm saying, what is the cardiac imaging in patients with cancer? Echo is recommended as the first-line modality for assessment of cardiac function in all patients. 3D echo is recommended whenever it is available. GLS is recommended in all patients if available. CMR should be considered for assessment of cardiac function when echo is unavailable or non-diagnostic. MAGA if echo is not diagnostic and CMR is not available. So I have just to say that you start by echo and then by the CMR if not available and by the MAGA. This is really very important. Of course, I have to say that the patient, this is really a very important item, and this is the recommended transthoracic cardiac magnetic resonance parameters to be seen. look what we look for the parameters. We look for the left ventricular size and function by Simpson technique, the GLS. We look for the right ventricular function as well, which is really very important. And of course, we look for the inferior vena cava diameter, the velocity of the TR, the markers of systolic RV function. What about in patients with Takotsubo syndrome, which is relatively present in patients with cancer? Of course, the imaging will be coronary angiography or multi-slice CT angiothesis will be class 1. Level of evidence C, and CMR is recommended to exclude myocarditis in this type of patients. And this is really very important. Workup of Takotsubo, as I have said, I don't like to be lengthy in my presentation, but I have just, this is important. Pericardial disease, it's really common in these patients. And you look for, this needs actually multi-modality imaging, echo, CMR, CT, ECG, measurement of biomarkers. Of course, if you have pericarditis, you can give these patients prednisolone and colchicine, and this is really very important. And what about the new recommendations have put a very important title about the end of cancer risk assessment. If the patient had the cancer and it's all gone, what should you do? You can, in asymptomatic patients, moderate risk patients, of course, you can do echo and serum biomarker within 12 months after completion of cancer therapy. And this is class 2A, and the cardiology referral is recommended when new cardiac symptoms is there. What about those having cardiovascular surveillance in asymptomatic adults who are childhood? They had cancer in their childhood. What you should do? You should do it every 2 years, who are at high risk childhood adolescents, and every 5 years if the patient had moderate risk. What about those in adult? What will you do? What will be your recommendations as a physician? Echo is at 1, 3, 5 years after completion of cardiotoxic cancer agents, and every 5 years should be considered asymptomatic, very high, and the early high-risk adults. Echo should be considered in asymptomatic late high-risk adult starting 5 years after radiation to a volume, increasing the heart rate and others. This is the long term. So we need to have a lot of patients now look for the long-term follow-up in cancer survivors. As I have said, this is the timing of how you do an echocardiogram for them. What about the coronary heart disease? Very common. Non-invasive testing is recommended in asymptomatic patients with moderate or severe radiation-induced coronary artery disease, and we need a multidisciplinary approach decision and do a preoperative assessment of lima viability, venous access, and sternal wound healing is recommended in those with having radiation-induced coronary artery disease. This is a very important explanation. This is a patient, as we can see, how advanced echo can help. As you can see, this is the patient having, this is a cancer patient, and having an ejection fraction 63%, 3D 60%, GLS 19. And when later, this is the 3 volume is the same, but 3 months later, you can see the picture below, and we can see that the left ventricular ejection fraction became 68%. It's increased low, but the 3D ejection fraction, it's decreasing, whereas the GLS is decreasing by 10% maybe. So this means this how sensitive you should look for the advanced echo technique and utilize these advanced techniques to look for the cardiotoxicity, the early detection. So in this situation, the GLS will be very important, and the 3D ejection fraction is very important, much more important than the 2D left ventricular ejection fraction. 6 months later, when the same is happened, so I think we do have to look for that. This is another patient is having heart failure, and this is an older patient, very old patient, and as we can see, the GLS is -6, and this patient particularly, I had received the sacubitril valsartan, and we can see that the impact of treatment proved that the patient becoming better. And this is one of the patients, I do have the honor to be a consultant of cardiology in the oncology hospital in Ismailia, and we have seen this patient. What about doing this transesophageal, and this is the patient. This is transesophageal epical. You can use this, and the 2-3D reduction, reconstruction in an old lady and it having a setting of metastatic. You can do this again. This is circumferential pericardial effusion, as we can see, and as you can see, this is again. It's not only pericardial; it's pleural as well, and this is a metastatic lung cancer. So you can see all the stress echo. There is, as I have said, this is not well delineated borders you can do. I have just a few slides. This is the 19 August 2022, and it showed that you can do the echocardiography and the cardiac MRI comparison of GLS in a cancer patients with immune checkpoint inhibitors. Actually, this is a new era for anti-cancer treatment, and it's seen that both will be very valuable. Again, this is another showing the same, and this is so subclinical systolic dysfunction. Again, this was 30 July 2022. Again, it shows that the advanced techniques of echo will help a lot in these type of patients. So this is the potential use of cardiotoxic. To put the subject in a nutshell, I have to say, just do a careful examination, ECG, left ventricular ejection fraction, and then you can just consider for the ejection fraction less than 40, look for the cardioprotective therapy if needed, non-cardiotoxic drugs, and then you can alternative use non-cardiotoxic treatment, look for the cardioprotective therapy, and look for the next step to temporary cancer treatment withholding. My take-home message is, of course, as cancer survivorship increase the incidence of cardiovascular disease, maybe a major risk factor. The whole spectrum is increased. It's really contributes to disruption of the psychosocial role of cancer patients. And therapy-related adverse effects are very important. And of course, definitely, cardiovascular imaging adds a lot and remarkable progress in this field but I have to say important item that you should receive psychological support for the patient and look for the patient needed a clear, accurate information about their condition. And this is we welcome to you to a very important, elegant event which will be in the 15th to 17th December. Heart, Diabetes and Kidney, make the link. This will be in Marriott, and you're all invited. Marriott Hotel, Cairo Marriott Hotel at this year, and thank you very much.
شكرا دكتورة جميلة على المحاضرة القيمة كعادتك. أنا بسأل سؤال. أنا عارفين الراديو والكيمو بيأثروا على الميوكارديال، البريكارديال، كورونري. بس once we have myocardial disease و heart failure، هل بنعمله زي أي heart failure ريف مثلا ك medical treatment ولا له سبيشال؟
هو المشكله حضرتك اللي بيبقى فيه سؤال واحد، يعني انا استشاري القلب في مستشفى الاورام في الاسماعيليه، ان بيبقى سؤال واحد، هنوقف will we interrupt الانتي كانسر ولا لا؟ هي this is the main issue. فالقصه بتبقى دي اول سؤال. السؤال الثاني بقى ان احنا we will give him anti failure definitely. السؤال الثالث can we prevent؟ yes we can prevent. لان can we prevent عن طريق بعض الدراجز اللي احنا بنشوفها، وطبعا if ان احنا نقدر نعمل سب كلينيكال ديتكشن للابنورماليتي.
I have a question for Professor Gamila. Excellent presentation, highly informative. So your advice for any cardiologist who is seeing a patient receiving chemotherapy to keep eyes on GLS and biomarker NT-proBNP.
Yes, definitely.
Then you have to estimate the risk of the patients before starting treatment, because we have different risk profiles, and accordingly the timing for doing an echo for biomarkers is important.
I think 3D echo will be very important. GLS is very important. If you are using conventional echo, you should be very meticulously looking for the patient, and I think we need to have advanced echo in these type of patients. Definitely.
Any question? Yeah. Dr. Ahmed Magdi.
Thank you for this excellent presentation. سؤالي بس لحضرتك، في recent publication على الدور بتاع ال SGLT2 inhibitors في ال prevention of chemotherapy induced cardiomyopathy. فتعليق حضرتك على الكلام ده، وهل
هو على فكره، بس انا عشان دور المحاضره بتاعتي imaging، لكن فعلا ال SGLT2 have some role الايس ليها دور، البيتا بلوكرز سم بيتا بلوكرز بيبقى ليها دور، الاربس ليها دور. وعلى فكره برضو في ايتم تاني في الناس اللي عندهم كارديو اونكولوجي احنا برضو بنقول الهايبرتنشن. الهايبرتنشن از يعني adjunct بروبلم كلينيكال بروبلم مع الناس اللي عندهم كانسر. وذيس تايب اوف بيشنت انا بس بنصحكم حاجه، ما تدهمش لا الفيراباميل ولا الديليتز، لان اكشولي بيبقى فيه كروس انتر اكشن according to the guidelines with the chemotherapeutic agents.
هو طبعا زي ما قالت بروفيسور جميله ان هي المحاضره ايمجنج، فوكسنج على الايمجنج، انما احنا ان شاء الله بكره معانا الكسندر ليون، ده اللي هو التشير بيرسون بتاع الكارديو اونكولوجي جايد لاينز. So he will present the whole guidelines of cardio oncology. He's one of the pioneers في الحتة دي. Okay. Any question لدكتورة جميلة regarding the role of imaging in patients receiving anti-cancer therapy?
طيب هل احنا نقدر نفولو اب باللونجيتيودنال سترين اللي هو يبقى ده ناخده كتول للفولو اب الايرلي ديتكشن او
طبعا ديفينتلي بس
اللي هو التريتمنت بعد كده او بنسميها ايه؟
ديفينتلي هو ده يعني المطلوب يا فندم، لان هو بس يعني احنا بنقول if available، لان it could be in some اماكن ما تبقاش available in every machine. So I think definitely this will add a lot. And as we said that the ejection fraction we are talking about is not, I think with the coming years it will be no more be there, because I do think we do have to have advanced techniques for detection of dysfunction.
I have an announcement before closing the session. Okay. الاناونسمنت احنا بكره ان شاء الله هنبتدي من الساعه 10، وبكره ان شاء الله البروجرام يعني فيري يعني كوندنسد ومليان حاجات مهمه جدا. هيبقى فيه الجايد لاينز الجديده اللي هي الكارديو انكولوجي زي ما قلنا، والبلمونري هايبرتنشن والنون كاردياك سيرجري. وبعدين في سيشن طبعا على الهارت فيلير، معانا روزانو اللي هو البريزيدنت اوف هارت فيلير اسوسيشن، ومعانا بقى سيشن قوي جدا على الايمجنج في الاكسبرتس في الايمجنج فيكتوريا ديلجادو، والسيشن ده طبعا هيكفر بقى التافي والايكو ديورنج مايترال فالف ريبير، وفي سيشن كامل على النيو كلينيكال ترايلز، اهمهم طبعا الاسكيميا اكستند ستادي اللي هي ببلشد في الامريكان هارت من اسبوعين. فبكره اليوم يعني مليان جدا، ومنتظرين تشريف حضراتكم، هيبقى من الساعه 10 الصبح ان شاء الله. اتفضل دكتور عبد الرحمن. دكتور عايز تقفل السيشن؟
شكرا دكتور مجدي، شكرا دكتوره جميله، واحنا بنند السيشن ونشوفكم بكره ان شاء الله. شكرا.